Hello to everybody joining the session. The number of people is still increasing, so we'll just wait for people to come in. Good morning, Joseph. We seem to have reached a sort of steady state at the moment, so I think we can start. Welcome to this session. Good morning, afternoon, evening, wherever you happen to be joining from. I'm absolutely delighted to be here today to chair what is this very important session in the THET conference about worker wellbeing. And we've got some really exciting speakers for you. Just going to share my screen. Just wait one moment, sorry. I'm having trouble sharing my screen, I'm afraid. Just give me one moment.
Can I try that for you?
Just give me 1 second, I might be able to fix it. No, I think you'll have to try. Sorry, Sarah. Lisa.
No problem.
Brilliant, thank you. I hope you can see that now. I can. So we've got 3 really exciting speakers for you this morning. Sarah Urasa is unfortunately having difficulties joining. Oh no, I think you've joined now, Sarah. So all of our speakers are here, which is fantastic. And we're going to hear from Steve Lee, who's Head of Health and Wellbeing at NHS England, from Sarah Al-Sheikha, who is going to talk about some really exciting work she's been doing around worker wellbeing, and from Sarah Urasa, who's joining us today from the Kilimanjaro Christian Medical Centre, who is also going to talk to us about her experiences. Next slide, please. Okay, so I'm just going to introduce myself. I'm Lucy Byrne-Davis, and I'm a health psychologist from the University of Manchester. And I run a behavioural science unit called the Change Exchange, which is about how change happens or doesn't in health systems. And so you might wonder why that's linked to health worker wellbeing and why I'm chairing the session. Obviously, I'm interested in wellbeing because I am a psychologist, but also very interested in the link between wellbeing and work. Next slide, please, Lisa. So the context of the session is that THET are having this inquiry into health worker wellbeing and global engagement and the links between those two things. And they began this inquiry in September with a webinar where people were talking about global health experiences and drivers of workplace wellbeing, and really trying to understand and pick apart how those two things are interrelated. And that is wellbeing of UK health professionals and the well-being of health professionals in low and middle income countries. And their findings, really, they talked about what the drivers were of workplace well-being, which are actually really well established in that relationships with people really matter, that safety and security within your job and within your environment really matters, and that you also really need a sense of satisfaction and personal fulfillment. And then they went on in that programme to talk about what we knew about that in relation to global health experiences. And really, there are these 2 key themes. One is that global health can be an intervention to support health worker wellbeing for people who are volunteering internationally. And the second, that we can't afford not to pay attention to wellbeing interventions as projects that we do globally when we come together in health partnerships. And so the whole kind of session is really going to think about those two things and how they relate to each other and the importance of global health within that. And I'm just going to give you a handful of concepts that I just want you to hold in your mind whilst we're going through the session today. Some of you will be really familiar with them. So the first concept is the concept of burnout. This is a really well-established concept. In ICD-10, which is the global classification of diseases, it's ICD-11, sorry, we're on now, that burnout is really an occupational phenomenon. So it's related inextricably to chronic workplace stress. And we know that burnout is linked to a huge number of outcomes for patients and for health professionals and health systems. So burnout is a really important thing. And it is characterized by three features: emotional exhaustion, cynicism, and inefficacy. So people basically become quite divorced from what they're doing, that they feel overwhelmed, and that work goes down, work capacity goes down. Next slide, please. So if we think about burnout, we think about chronic stress. There's very, very good evidence as well that shows that how we perform in any role is very linked, symbiotically linked to how we feel, to the stress that we feel. And I thought this was a really interesting point here from a fellow psychologist from Greece, who says that the fact that we don't talk enough about stress and performance is linked to the myths we have, he says, of the heroic physician who's resilient, who's expected to lead, who's expected to kind of take everything on. But actually, this could be just as well nurses as angels, or any healthcare professional as being someone who's responding to a vocation. So as soon as it becomes something about them and their identity, it seems that we can pile stress on top of people. And we're really pushing back against that, both for that person, but also for the impact that that has on performance as well. Next slide, please. Okay, so this thing was really interesting in the UK. When we realised that COVID-19 was going to overwhelm health services in the UK, people started to put together things about how to work where there is a high risk of what they call moral injury. So this is basically not being able to act in alignment with how we think we should act. And what was really interesting, this Support the Workers website was created by people who had worked internationally in low resources before, who'd worked in humanitarian crises, because they were basically saying this, in the UK, this is going to be a fairly novel situation in terms of working with such high demand and such potential for psychological injury as a result of that. And similarly, groups of health psychologists translated some of this frontline evidence that was created in places like Support the Workers, so that they could work with managers and leaders within services to think about how they can mitigate those things by how they create spaces for their staff and support their staff well-being. So that was really interesting. I guess that learning that came from global experiences where low resource and humanitarian issues are much more prevalent than they have been in the UK. And the final concept I'm going to just touch on, next slide please, is this idea of life satisfaction and how it relates to global engagement. So we did a study a few years ago where we tried to pull together all of the evidence on the benefits of international volunteering or international placements in low resource settings for the UK workers who were volunteering. And we synthesised this evidence, and we found over 100 items that were both core to health professional practice and were developed through international experience. And I just pulled out a few there on that slide, just really to show how they are really things that are inextricably related to well-being. So our ability to cope, how we revise our assumptions and develop new perspective, the fact that we're flexible and adaptable, that we can adapt to unfamiliar situations, which is related obviously to the ability to cope. Increased self-awareness of who we are, what we're doing in the place that we're in. Lots of items were related to appreciation of our own situation, our own lives. People talked specifically about increased job satisfaction, and then this idea of life satisfaction or personal satisfaction, that we appreciated our lives, we felt personally fulfilled by our ability to give. And this very much relates to one of the 5 ways to well-being, being giving. So certainly from a UK health professional perspective, there's actually a lot of evidence in a lot of literature that there is an important impact on well-being for people working internationally. So that was just setting the context for you. I'd like to call on our first speaker, Steve Lee, and I'm going to let him introduce himself, and he's going to be talking to us about his work in the NHS. What I'd really like you to think about is what questions you'd like to put in the Q&A. If there are sort of clarification questions, we'll come straight back to Lee at the end of his talk. But if they're more sort of for the general discussion, then we'll park them and come back at our general discussion place. So over to you, Steve.
Thanks very much, Lucy, and I hope you can all hear and see me. And thank you very much for welcoming me along today to talk to you about health and wellbeing in the NHS. Before joining the NHS, I worked in several government regulators, including a regulator for medicines, RAL, and the health and safety at work regulator, where I worked as an organisational psychologist responsible for developing management standards on work-related stress. And those standards look at elements of work organisation and job design that, if aren't properly managed, can lead to ill health outcomes. I'll take you through today very quickly where we are with our health and wellbeing offer for staff, and welcome any questions towards the end of this, because I recognise that I will be cantering through. So if I could get the next slide, please. So at the height, or at the start of the pandemic, we received a significant number of offers of help from app providers such as Headspace and Unmind. And we gave those services to our colleagues. They were all accessible free of charge. And you'll see there around 224,000 staff have used those. Around 10% remain active users. In addition to the apps, we created a devoted website on health and wellbeing, and that's rapidly approaching a million kind of interactions with that service. We've also got helplines that have been supported to us by a charity called the Samaritans and Hospice UK. But alongside those reactive offers of support, we've also been proactive in terms of offering primary care sessions around coaching, around wellbeing, and that continues to be deployed. We've created an inclusive health and wellbeing offer where we are reaching out to protected characteristic groups to ensure that the offer resonates. Building on that, we've worked with an organisation called the Invictus Games Foundation, which supports ex-military personnel to develop a physical health offer that kind of works across the whole spectrum of NHS employees. The recent campaign we've done there is something called the 5K Our Way, which encourages people of any ability to participate. So you can run, you can walk, you can roller skate, you can do whatever you want to participate in this doing 5K Our Way. The feedback we've had from that is it's really helped to bring teams together in terms of a common goal and common objective. Because of the ways we've been working as well, we've held a significant number of webinars to reach out to colleagues across the NHS, and bearing in mind there's now around 1.4 million people who work in the NHS. So we have to kind of adapt the way that we communicate during the pandemic and the ways that we're reaching out to people. The great thing to see is that social media is really helping us get our messages out there. If I could get the next slide, please. So the offer that we provided at the start of the pandemic was absolutely the right thing to do. We offered support at an individual level. However, that support isn't at an individual level. It requires you to decide what you need at that point in time. There's no real feedback to organisations. So we recognise that we need to start to change focus, and our focus for the coming year and beyond will be across these three main areas to ensure sustainability of the offer and the approach. The first is to get top-level commitment within organisations. So we have created Wellbeing Guardians, and those Guardians we are providing support to, for example, through things like masterclasses to help them understand what their data is telling them, and through the creation of a dashboard that we've worked on with the Thomas Ashton Institute, and I'll share a bit more about that later. To go further into organisations, we recognise that we need to equip line managers and teams with the tools that they need to take ownership of health and wellbeing, and that health and wellbeing is discussed routinely. The main vehicle for enabling this to happen is called our Health and Wellbeing Conversations piece, and they're what we're expecting our colleagues to have just routine check-ins with each other. When we first launched Health and Wellbeing Conversations, we were asked how these were to be recorded, the frequency of conversations, and our sense was that was the wrong pathway to go down. These just need to happen routinely, and if we said they had to happen in a given frequency, they could potentially turn into a tick box exercise. And the third and final area is around providing rapid access to mental health support for colleagues. We've now established 39 out of 40 mental health hubs, and allied to that is work that we're undertaking with the occupational health community to ensure occupational health becomes an integral part of a preventive approach. Just to quickly go through those three areas in a little bit more detail. As of this week, it's now 85% of Guardians are in place in large organisations, which is massively encouraging to see. The ambition is to get 100% coverage by the end of the calendar year. We've put in place support to help Guardians and boards understand data. We're keen to encourage organisations and boards to look at more upstream preventive interventions that will resonate with staff. And everything that we're doing to support Guardians doesn't introduce burden. So the work that we undertake across the programme, you can already find that, you can track it back to existing requirements in regulation, for example. But our whole approach is to kind of help people fulfil their duty of care, and to do that by using existing metrics, such as a pulse survey that takes place every month and has done since the pandemic struck, and a yearly staff survey. If I could get the next slide, please. So in terms of the support that we're providing to Guardians, we've created the dashboard, which sits on our model health system. Anyone with an NHS email address can access the model health system and have a look to see how their organisation is performing. And you'll see there's a purple cross on wellbeing. Just in terms of that, the compartment that sits on the model health system, the Thomas Ashton Institute, which is a collaboration between the UK Health and Safety at Work regulator, the Health and Safety Executive, and the University of Manchester, helped us to look at the indicators that could provide both a lead and lag indicator of wellbeing performance, health and wellbeing performance. So what do we mean by lead indicators? Well, lead indicators are those things that you can influence upstream that can yield positive outcomes. Lag indicators are typically those things that have happened after the event. Within the NHS, we often look at lag indicators, and the focus of attention on health and wellbeing can be on lag indicators, for example, sickness absence or presenteeism. What we're saying is that we want organisations to look at those lead indicators, to look at the things that they can influence, for example, around the psychological safety climate, the demands that people are under, and the environments in which they work in. If I could get the next slide, please. So this just gives you an indication of what you get on the model health system. So your organisation will be on that black vertical line, and you can do comparisons with other organisations of a similar size or within the sector. You can cut the cake in a number of ways, depending on what your lines of inquiry are. But the hope here, the ambition here, is that the organisations engage with each other, they talk to each other to find out what is working. But also the organisations don't necessarily react to things like a higher than average sickness absence rate if they are assured that the things that they're putting in place upstream will in time reduce those absences. The massively important thing to say here, though, is that these are just indicators of performance. What organisations need to do is to get behind that, to find out what is going on, and to engage with staff to find out what will work in the future. If I could get the next slide, please. I mentioned health and wellbeing conversations, so targeting kind of line managers and teams. What we're really keen to do, people, it's often said that people leave line managers, they don't leave organisations. However, we're also keen to ensure that line managers feel supported when undertaking conversations. So in addition to guidance, we've produced training materials for line managers and others, and that's available to all parts of the NHS. Anyone can enrol, and it provides you with the skills that you need to undertake conversations routinely and confidently, so that you feel equipped should a colleague come to you with a condition that you're uncertain about. You know how to handle that, and you know how to signpost on to somebody else who may be able to help. It's all around confidence building. In addition to those kind of one-to-one training sessions, we're holding, in addition to those one-to-one sessions, we're holding trainer sessions to enable conversations to be embedded. We do track and monitor conversations, but we do that through the Pulse survey. We don't do it as an intrusive way. We ask a couple of questions. Have you had a conversation? And did you find it helpful for your health and well-being? We know that over 60% of staff have had a conversation and they're finding them beneficial, but we're keen to ensure that that momentum is retained. If I could get the next slide, please. I'll canter through the next 3 slides because I'm aware of time. But occupational health services within the NHS, it's fair to say that you get a variation in terms of the offer. Often seen as a passive service or a back office function. And we're keen to ensure that occupational health now becomes much more an integral part of a preventive model. There are the drivers there that you'll be able to see on the screen that are enabling us to move forward. But there's also 10 projects that we're working on at the moment to ensure that we deliver occupational health services consistently within organisations, and that they are part of an integral preventive message to organisations about what can be done upstream. Some of those, I'll break these down into sort of 2 main sections for me. The first section is around some of the infrastructure issues that we need to contend with, for example, around standards, around design principles, around the use of technology across occupational health. Different systems exist. But allied to that, and equally important, is around perceptions, how occupational health is perceived. At the moment, occupational health is often seen as somewhere where things go wrong, or if individuals have hit sickness absence triggers. We're keen to kind of modify that, to change the way that organisations perceive occupational health and use occupational health, to help them kind of gather intelligence, to help them design interventions, and to help track and monitor what's going on. If I could get the next slide, please. Just to kind of share with you some of the phases of activity that we're going through to enable that shift, really, from that passive model to a very proactive model, and one that you can expect to gain in momentum over the coming years, but also to deliver consistency across the piece. I'll go to the final slide, please. So just in terms of measuring impact, we do this in several ways. We do this quantitatively through surveys. We do it qualitatively through hearing feedback from the sessions that we run, and hearing back from things like the occupational health community about how our proposals are resonating. We do a lot of work by sector, though. So we work closely with the ambulance sector to provide health and wellbeing support, and also the critical care colleagues, where we've been providing proactive support under incredible pressure. We also undertake work by topic. So, example, we undertake significant work on violence reduction. We've issued body-worn cameras to all 11 ambulance trusts across the NHS to both secure prosecutions, if that's a route that we need to go down, but also to act as a huge deterrent. We undertake significant work around the inclusion agenda, and that is something that we hold dear to our heart and will continue to pursue. And also the physical health offer. We recognise the value of physical health and the dynamic that has with psychological health too. Finally, we'll work closely with regions. So while I work at a national level, I also work closely with 7 regional colleagues to ensure that our offer talks to the local context. So we recognise that one size doesn't fit all, and there isn't a silver bullet for health and well-being, but what we're encouraging people to do is tailor the offer to their context and their environment, and work out for themselves what works. So that's a summary for me, and I think it's back over now to Lisa or to Lucy. Back over to you, Lucy. Thank you.
Thanks, Steve. Thank you. That fascinating and really amazing to hear about the level of health and wellbeing interventions that are happening in the NHS. We haven't got any clarification. Oh, we do. Kit, if it's okay, I think, and Yosef, I think we'll leave those questions for the end discussion, because I think they're actually key to the whole session today. So thank you for those. I'm going to move swiftly on to introduce Dr. Sarah Urasa, who is our second speaker today. And Sarah, if you can start by introducing yourself, you're very welcome.
Thank you very much, Lucy. My name is Sarah Urasa. I am a physician and currently serving as the Director of Hospital Services at a large referral and university teaching hospital in Tanzania, in northern Tanzania. This is the Kilimanjaro Christian Medical Center. It's a rather big hospital for a country like ours. It has a bed capacity of 634 beds. And given its location, it bore the larger burden of the sickest patients in the zone. So the experience that we had at KCMC, that our staff had at KCMC, was first, given the political situation that we were in 2020, the uncertainty. There was uncertainty, there was fear of the unknown, and like elsewhere in the world, the stress of staff witnessing multiple deaths and taking care of very sick patients. There was also an issue of denial among patients and among family members, also given the political stand that we were in the last year. So patients were inevitably brought in very sick. And if it happened that a loved one passed on, then there was a lot of blame on our staff. So that was also very stressful. And certainly, like elsewhere in the world, there was a lot of burnout. Our doctors, for instance, only had 1 to 2 weeks off the COVID unit, but they were not off their other duties in the hospital. So this was really a stressful time. And this was even worse for nurses, because they would have maybe 1 or 2 days off, and then they would have to be back on the team again. This is because even though Tanzania at the moment has quite a number, I think we have 9 medical schools, all producing quite a significant number of medical students and nursing students. So we have a scarcity of human resource in the presence of plenty. So the picture is rather different compared to elsewhere. So what helped us at KCMC is because Tanzania, and certainly northern Tanzania, is largely a religious society. So there was a lot of faith involvement, and KCMC, being a Christian-owned hospital, has a chaplaincy department. So the way the chaplaincy department was involved was they would have daily devotion services, like 30 minutes after the team has had their morning report and before they disperse to different sections in the units. And this really helped. And we also have a mental health department. And this mental health department staff were integral members of the team. So they would take care of the patients and also of the team. So usually they would have weekly team sessions. And if a staff member saw they need to, they would have individual sessions with the staff member. However, this is not a standard in Tanzania, because it largely depends on the institution, the ownership of the institution. So if it's a faith-based organization type of institution, then there would be more chaplaincy type support as compared to a government-owned institution. Also, what helped in our situation was family involvement. Being in Africa, there's a lot of family involvement in taking care of the sick. So relatives in our setup, relatives were able to not go into the rooms per se, but the kind of setup we have is one where the less sick patients were able to go out, take a walk within the area of the unit, or just sit in the sun for a while. So relatives were able to see their loved ones, the less sick ones. And also what helped was the hospital administration, the management team was also very involved. We would daily in the morning also go see the team, speak to them, at times work in the unit just to show that we were with them. However, as I said, this was not the standard in Tanzania because we do not exactly have a structured occupational health system. So in summary, that's it from me. I'm happy to take questions.
Thank you, Sarah. Really insightful there. There is something, let me just check in the chat. Yeah, Kit has mentioned, and I was thinking this when I was listening to you as well, that the absence of relatives in UK hospitals has been really a bad feature and still ongoing actually in care homes. I was listening to a colleague yesterday talking about how people in care homes are still not, some care homes still not allowed visits from their relatives. So you said that you were able to maintain that with people who were able to go outside. Was that the case with your more sick patients, or were relatives also excluded from that?
No, so for the sicker patients, they would be in a section of the unit where the relatives could not access, unless on really special situations. They would ask, but by default, we wouldn't allow them into that section of the unit. If they could speak or see their relatives through a window, then they would be able to do that if they were on the ground floor. However, those on the upper floors, that wouldn't be possible.
Okay, thank you. Thank you, Sarah. I think there'll probably be quite a lot that comes up in the later discussion, adding on to what you've spoken about today. And I'm going to introduce our second Sarah of the session, Dr. Sarah L. Shaker, who's going to talk to us about a really innovative bit of work that she's been leading on. Welcome, Sarah.
Hi, thank you so much everyone for having me today. Real privilege to be talking to you about wellbeing, which is something I'm truly passionate about. Just going to get up my slides, so just 1 second. Perfect. So today I'm going to be talking about mental health of staff working in critical care during COVID-19. And this was a study, a joint study between King's College Hospital and UCL. And our study team was a group of clinicians. So myself, Kate, Michael and Kevin, who are all critical care and intensivists, and Tristan, who is a computer scientist. And we've also had some support from Professor Neil Greenberg, who is a consultant in occupational and forensic psychiatry in KCL. Professor Neil Greenberg as well is a military psychiatrist and has had deep involvement looking at PTSD from military veterans during the war in Afghanistan. And the real purpose of why we started this study was during the first wave, we heard a lot from our colleagues about people being tired. And we were concerned that there was actually significant psychological trauma that was happening to our colleagues who were working within critical care that wasn't being captured. So we've designed a unit climate survey, and the aim of this really is to collect longitudinal data which will show us about the impact of wellbeing and on a unit, looking at specific time points and looking at specific pressure indices to determine about what is influencing the impact of wellbeing on that unit. We've used validated question sets. So this has already been used in other forms of psychological research. And the main caveat with this data is that it's suggestive and it's not a diagnosis, as it is a short survey. The survey is online, so it's an online link which is sent through a department. But the most important thing about it is that it's anonymous, because what we found looking at previous research is that if people are concerned that the data is going to come back to them and can identify them, then people don't answer honestly. So we've made sure that it's really clear that this is anonymous at the point of collection. We've also made it very short and succinct to try and encourage people to complete the survey. And so far, this has been successful. So really proud of the work we've been doing so far. So we've got over a year of longitudinal data. And we've got nearly 50 hospitals that have been recruited and over 11,000 responses in total. To be valid for a department to show kind of that snapshot picture, we need at least 15% of the workforce to have completed the survey. And we're, like I've already mentioned, this is providing some longitudinal analysis, which we're using against capacity pressure indexes to assess the well-being of the department, but also to get those understanding about what actually causes the tipping point for well-being to deteriorate within a department. So we've already successfully had one publication, which was from our first round of the survey. And the real key take-home messages, is that PTSD was incredibly prevalent. So what we found from the first wave of COVID was probable PTSD was around 40%. And to put this into context, the previous highest recorded rates of probable PTSD was from active veterans in the Afghanistan war, which was 17%. So we were over twice what has previously been recorded. So it was very significant. Another take-home message as well is looking at probable PTSD, anxiety, depression, and use of alcohol at nearly 50%. And unfortunately, this is data from the first wave, and now we've got 8 waves of data. And we've managed to collect data during real pressure points. So for instance, in January, February time, when we were suffering from the third wave of COVID. So these numbers are only the tip of the iceberg. And unfortunately, we've seen an increase in the numbers as the pressure has increased on critical care capacity. Making this kind of relevant to other research that's out there. I mean, we've said that PTSD at 40% plus, is this a problem? Yes. It's common sense, but actually sometimes we need to be looking at what already exists to kind of prove this. And what we found is that looking at work from Afghanistan is that with having PTSD, it affects all of the aspects, so your physical health, burnout, and most importantly about patient safety. So looking at being able to perform at work effectively seems to have a direct correlation with PTSD. And interestingly, even a slight increase in the PTSD score seems to have an effect on impairment. So just a little change can really have a significant impact on patient safety. And like I say, one of the real beauties of the data that we've been collecting in this longitudinal analysis is even though we're collecting snapshots along the year, it's showing us the general trend. And what we're finding is that when we're looking at the military data, and you can see that people are on deployment for a fixed amount of time, there's some element of recovery after they've had that exposure to that traumatic event. And one of the things we're seeing within our workforce is that this is a prolonged event, 18 months, no real rest. And actually, we're expecting that services and pressures are going to start increasing again with the demand for elective, but also a winter with COVID and flu. And we're finding that our recovery is starting to arrest and that we're reaching levels that were higher than they were last year. And it's really quite interesting to see how we're going to be managing that, and how as an NHS and a national organisation can we get the balance of making sure that our staff are rested and safe to work, but then also that we can provide safe patient care. So the impact that we've had so far with the survey and the next steps. So sorry, I didn't introduce myself properly at the beginning, but I'm a national clinical advisor for NHSX, so that's the clinical arm of the NHS. But and I'm also an anaesthetic registrar who's had previous experience working in Zambia. So this is why I'm so passionate about the impact this could potentially have with LMICs. And during my work with NHSX last year, I was seconded to NHS England, working with the EPRR team, helping with the national critical care response. And this was meant that when we did the survey and we were collecting this data, we were able to immediately escalate to the most senior tiers of NHS England to make them aware of what was actually happening on the ground. Something that has been really important with this data and looking at the pressure indices is using this data to actually utilise in the COVID response. So we found that as soon as a unit got over 120% capacity, this appeared to be a tipping point for wellbeing scores to deteriorate. So following that, there was a national policy for trying to decompress units. So rather having a unit running at 200% and then a unit running at 90%, transferring patients from the 200% to the 90% to try and even the load, to try and prevent that unit that had 200% having significant deterioration in their staff wellbeing. Kind of linked to what Steve's been also mentioning again, lots of funding and resources have gone into psychological support for the NHS as a whole, but this data has also been used to actually support ring-fence funding for psychological support in critical care. And this is actually where I'm kind of a little bit more passionate about this data and thinking about the local impact of it. One of my biggest learning points of being involved in this wellbeing work is the realization that actually the secondary, tertiary care, so when we're thinking about psychologists and talking therapies and all these different things, actually don't have the same impact as primary prevention. And when we're thinking about primary prevention, that's making sure that we've got enough staff, enough resources, people are paid, people feel safe. Those kind of things are actually the most important things we can be doing to support our staff. And when we've collected this data, all the units that have participated receive their own individual data back. So they receive the national picture, but they also receive their data, which they can use for their own internal resources. And we've had some really fantastic feedback from some of the units. So some of the units have used it to procure resources such as psychologists and staff support, but I've heard of other units that have used it to actually make the argument for having resources such as bank nurses and making sure that people are getting study leave and annual leave, which makes me really proud that this data is actually being utilised effectively by the local partners. But what I'm really here to talk to you about today is that I'm really passionate about thinking about, can we actually implement this in an LMIC? What we've shown is this methodology works within the UK healthcare setting, but actually the methodology for it, from my previous experience in Zambia, I hope would also work in an LMIC. And the reason being is if there's no data, there's no change. And this was a very low cost and effective way of collecting data that actually can have a national and local impact. And ultimately, the primary aim of our group really is to start a culture change of incorporating wellbeing as a key metric. So as we look at, efficiency, productivity, staff wellbeing, and therefore patient safety should also be included in there as well. And like I've already mentioned, this data can really empower departments and really provide scientifically validated evidence to help them influence change as well. So it's that real two-pronged approach of, from a national perspective, having that data so that you know where you need to be putting your resources and where you can influence, but then from a local perspective, actually seeing what's happening on the ground and what changes you can make. So if anyone has got any feedback they'd like to give me, or interested in joining us for a feasibility study, or have any thoughts and opinions about what we need to be considering, there's my email address, so please get in contact. Thank you.
Thank you, Sarah. That presentation was both fascinating and worrying in sort of equal measure, and very, very interesting. I'm going to kick off our general discussion. I'm going to ask everybody attending, please do think about your own, don't be afraid to speak up. You can raise your hand and then I can call on you, or you can pop things in the chat or the Q&A. And I'm going to begin with asking questions from Sarah El-Shaker. Lisa has asked, how has your global experience helped you in the work that you've been doing in the UK during COVID, and also your personal well-being?
So in regards to my experience from Zambia, Zambia was the first time I was ever tested with wellbeing. So it was in 2019 when I went, and it was the first time I really saw burnout, and I really saw the impact of having low resources and seeing how staff were coping with not having annual leave. And it made me really reflect on my experience of being a trainee in the UK, and has made it something that I've been incredibly passionate about since I've come back home. And when COVID started to happen and I started to see friends become tired, it made me really think about how can I support them and how can we make things better? And quite fortunately, within my deanery, they've been very supportive of us as trainees. But even still, and looking at the data as well, it's shown that if you're putting people under the extreme pressure of not giving them annual leave, not paying them, and making them work, and seeing death on a daily basis, it does impact on people. But that's why I'm so passionate about this work and trying to drive it forward, because I really do feel that without this data, that we're not going to get the change. And this is why I'm really pushing for thinking about how can we implement our lessons learned from a UK perspective into LMICs, because actually I think this data would be incredibly helpful for an LMIC. So for instance, if you've got a country that's putting a bid in with a international partner, you could actually say, we need resources for this, and this is the impact it's going to have on well-being. So that's my kind of connection between what I've learned from Zambia and what I hope our lessons learned from the UK could be translated back to an LMIC, really.
Thank you, Sarah. And Sarah Urasa, can you tell us about your partnership with Northumbria? And again, Lisa has asked this question. Do you think that your health partnership experience, or the health partnership being a partnership, supported the well-being of staff in Kilimanjaro Christian Medical Centre and in Northumbria? Do you think that there was any benefit to well-being of the partnership?
Yeah, thank you, Lucy. Yes, I think so. I believe so, because on the KCMC side, on the Kilimanjaro Christian Medical Center side, our staff formed new friendships with the Northumbria team, and people have actually had a very long-standing friendship. There's some people who've been friends with their colleagues in the UK in Northumbria for 20 years now, throughout the duration of the partnership. And it gives staff something to look forward to. It's actually an exciting time at KCMC in November, usually when the Northumbria team would come to KCMC. So last year was notably very different at KCMC, and KCMC is usually a very vibrant community with visitors all the time. And in November, the Northumbria team is really something people look forward to. So in 2020, they didn't come, and that was something that the staff noted was missing. I believe it's the same for the Northumbria team as well. When they come to KCMC, they get to form these friendships. For them, I think it can also be a holiday, depending on how much time one gets off from work back home. So they, given our location, they get time to see the various attractions that Tanzania has to offer. So for them, it's a good time off work. They get to see how we can achieve what we achieve with our limited resources. So there's a lot of improvisation at KCMC, given our limited resources. So I think one thing they learn, not directly linked to their well-being, but something they can take home with them, is how to work with what is available. Maybe that's not directly linked to their well-being, but yeah.
Yeah, so that's fascinating. So the two things there really is that value of friendship and I guess camaraderie. Again, it's always interesting for me as a psychologist when I see two midwives together or two nurses together, and you can see that there's just an immediate, these are my people. This is what this is, an immediate understanding, and that's really interesting. But also the learning, the very practical learning of high stress, low resource sort of environments, and they're beneficial. Both sides around that. That's very interesting. There's a question there from Dorcas for Sarah L. I'm going to call you about diaspora and how they are vulnerable to poor mental health. And Dorcas is asking, how can we embed culturally acceptable mental health programs for Black and minority ethnic staff working in the NHS?
So anyone who hears me talk about this is going to get fed up of me saying with no data, there's no change. But that's one of my biggest learnings of working with with senior NHS for 18 months, is that if we don't have the data, then we don't know what's happening. And part of our survey, one of the metrics that we do collect is looking at people's ethnicity. And so from a national perspective, we can see, how different groups are responding and what their particular rates are of PTSD, anxiety, and depression, and those kind of things. And one of the beauties about collecting longitudinal data as well is that you can make an intervention and you can see the impact. So if we're collecting data that is specifically looking for this, then that's a way that we can see if our interventions are actually making a difference for people from different ethnic origins as well. But I do definitely think it is something that's overlooked, and it's one of those things where we tend to give a very, very generic offer rather than giving anything that's kind of specific for different groups. And it's when you're doing things at scale, it's very difficult to try and think of that specific user need and to make sure that it is fulfilling all of the user needs. But that's why I'm so passionate about collecting large volumes of longitudinal data so we can actually start picking out that user needs. I don't know, Steve, do you have any thoughts about this?
Yeah, happy to. So you're right, kind of data is key, and we do gather it in terms of specific health and wellbeing support. I mentioned the inclusive health and wellbeing offer that's in place. Only been going recently though, so we're really keen to kind of track and monitor the impact of that. But just to share some of those things that we're doing, there's a looking after you too piece under there, which is looking at wellbeing coaching for frontline ethnic minority staff. Doing some work as well around nursing and mental health, the mental health of nursing, mental health awareness training, particularly with a focus on ethnicity, disability and sexual orientation. Faith counselling as well, faith counselling and spirituality, understanding the importance of that for staff. So it's one that we're keen to advance, and it's one that we're keen to kind of pursue and understand the impact of that. The really encouraging news is every time we do put an offer out there, they're oversubscribed. So that's telling us something, that there is a need out there. We're just really keen to ensure that forms part of something that's really welcomed by staff, but also in turn folds into that preventive model. It's not seen as, this is the answer to health and wellbeing, is, to kind of buy in a service. It's more around how does this fit into a big, part of a much bigger jigsaw.
I'd just like to bring in Yosef's question now, which he asked actually very early on, and it's a really interesting question. So he's asking, do workload and stressful work actually have a role to play in development? Or are they always harmful? And a sort of secondary part is, can prevention of exposure ever be a strategy to address harms in that way? Don't know if yeah.
I'm happy. Yeah, I'm happy to kick off anyway, and others can contribute. So when I worked in a health and safety executive and we designed the management standards for work-related stress, the strongest evidence we found was from something called the Whitehall 2 studies, looking at the dynamic between demands at work, control at work, and the amount of support that you received. So if you have too low a demand, that can almost be as harmful as too high a demand in terms of people, not fulfilling their potential, or, rust out, those kind of things, as opposed to burnout. So I think it's important to get that balance right. The thing that Whitehall 2 was telling us, though, was that support is massively important. Support from your line manager, from your co-workers, was found to have almost a protective effect against either too high demand or not enough control at work. So you'll see, if colleagues, I'm sure I can share links with colleagues, kind of the sort of national regulator looks at kind of 6 main areas of work organisation and job design. The top three with the best evidence were around demands, control and support. So I think it's all about getting that balance right. I think and I think that's one that organisations themselves need to respond to. But I think it's worth saying as well, kind of those standards that were produced, the evidence base had to be high. So a regulator would have to go into kind of, a court of law potentially and prove beyond reasonable doubt that there was a breach against those kind of standards. So the bar is high. So there are tools and techniques out there that organisations can use. They've got to want to use them. I think that's the thing. I think too often organisations think, health and well-being, that's a bit soft, that's a bit fluffy. Can we buy this service in? Can we do something? Actually, the hard yards are around, kind of making this, working out what's going on organisation, engaging with your staff, using the evidence that tells us what works, and then kind of seeking help when you need it, but getting help from the right places.
So
that's really helpful, Steve. Thanks. Go on, Sarah.
Sorry. One of the things that we've been doing a deep dive exploration in with our data is looking at teamwork and leadership. So exactly what Steve said about the impact of if you have a strong team in leadership, does that impact on your scores for things like PTSD, anxiety, and depression? And then we can cross correlate that with looking at the pressure indices as well. So really determining about how much of an impact this is. As previous research does show, like Steve said, that if you've got a strong team behind you, then that's going to be quite protective. And one of my kind of big lessons from being a clinician, being in this environment, is that with anaesthetics and critical care, we're very often exposed to quite extreme and harrowing situations. And some places will do things like, training and sim beforehand to make sure that you're ready and resilient for it, and then formal debriefs afterwards. And then there are some departments where you don't get that kind of debrief afterwards. And when you're looking at the military models and actually how they look after staff and protect the staff, I think there's actually quite a lot of learning that we still need to be doing and translating from different areas and organizations, and about how we can make sure that people are appropriately supported during these extreme situations as well.
Thank you, Sarah. Just a comment there from Judith saying, would it be worth sharing experience with the Army? Because they've been looking at too early diagnosis of PTSD, and that idea that humans do have resilience, have the capacity for resilience, and what it takes to be resilient. I think, as always, there's actually really good evidence for what we should be doing, and I think that's that there's lots of research over years, both in the kind of research that Judith's talking about there around early diagnosis not being the right thing to do, and how much is too much, and the effect of control, and all those things. And the question is really always about implementation. It's we, even when our discoveries are pharmacological, it takes us decades to get them, to get practice changed within any of our health services. And so it's very, very difficult to get things implemented. So it's great to hear about these developments that are being implemented in various places. I'm going to draw us down to something that's slightly more ethereal at the moment, which is Jehoon's question about what are the pitfalls or limited ways of thinking that we should be aware about when we're discussing well-being. Now, I confess that I'm not sure. I don't know, Jehoon, if you want to open your mic and maybe talk a little more about that, or whether I can pass that straight over to one of our speakers, if anybody wants to answer that.
I've got thoughts, but I'm aware I'm talking quite a bit. But I think the biggest pitfall, and actually goes back to what you were saying, Lucy, about the hero complex, and that in healthcare, we're often trained to think this is a vocation, and that it's not okay to admit that we're struggling. And one of the biggest things that shocked me during the pandemic is people that I determined before as being strong, actually going off on sick leave with stress and anxiety, and which has made me realize what kind of situation people are working in during this, and that we've all got the potential of being pushed over the edge for mental health. But a lot of the focus that I've found anyway tends to be about the secondary and tertiary prevention, the secondary and tertiary treatments, rather than the primary prevention. And the primary prevention being, actually, we need to develop strong teams. We need to make sure we have resources. We need to make sure that we're looking after our staff, which quite links back to actually the point we've just been talking about with PTSD, because actually when you're looking at trauma and an isolated incident, typically there will be some arrest of those PTSD scores. So when you're looking at the scores in January, for instance, with COVID critical care, we had very, very high scores. Whereas when you look now, it's not as high because there has been time for that recovery. So when we're looking at, so if you were to put all the money into secondary prevention there and, you know, treating everyone for PTSD, that would be the wrong thing. But what we should be doing actually is talking about how can we strengthen our teams and make sure that our staff are safe to work. And with that, we need to be focusing more about the primary prevention of how can we strengthen our units.
Thank you, Sarah. Anybody else want to come in on that?
Yeah, I'm happy to as well. I think it's I think the risk is just seeing health and well-being as just one dimension, you know, that belongs to one person, typically in HR, that's responsible for health and well-being. It's responsible, you know, it's for all of us. And I think as well, getting stronger connections to other important organizational metrics around things like attractiveness as an employer, around retention. You know, if you get health and well-being right, you're more than likely to retain colleagues. I think as well, you know, we've seen, you know, let's try and move away from sort of fad-based interventions or bursts of activity in response to, say, for example, Mental Health Week, and then we think that's it, job done. It's similar. There's so many overlaps, I think, between the work that we're pursuing on health and well-being to inclusion. I think often organisations think, oh, okay, if I do this activity in this month, then that's going to be okay. Whereas it's an ongoing thing that you need to have and to continue to have at the top of the agenda. And one thing, probably the only thing that's, you know, that we've seen as a positive arising from the pandemic has been how now staff health and wellbeing is close to, if not at the top of the agenda for many organisations. The thing for me is how do we keep it there when we've got so many other competing priorities around, for example, elective recovery, winter pressures, but without protecting the health and well-being of staff. I think we're just looking at short-term solutions as opposed to long-term benefits for the NHS overall and any other large organisation.
That's really interesting. Evelyn has posed this question: are people in the NHS really open to learning on it from our LMIC colleagues and diaspora staff? And I guess this comes back to that whole how bi-directional are our bi-directional partnerships, and how much are we open to learning in the NHS from people who are more experienced in certain situations than we are? And I guess the question is, I've got for for Sarah and anybody joining us from a low resource setting, is what could help the NHS to learn? What should we be thinking about more when we're thinking about our staff wellbeing? I don't know, Sarah, if you want to come in there.
I think the NHS should probably encourage more international partnerships, such as the one we have with Northumbria. I think they're beneficial on both ends, because not only can they work in bringing us the experience that the UK has and assisting us, but they can also come here and gain experience from us. So, for instance, having placements, short-term placements of staff from the UK, from the NHS Trust, coming to spend some time in lower and middle-income countries.
Great. And that leads us really nicely, actually, onto a question that's appeared in the chat, and I know is at the heart of THET's work in this area, which is really, it's to Steve initially. Could global health engagement opportunities contribute to the overall health and wellbeing offer to NHS professionals? And if it could, how? What would be the route for that happening?
Yeah, I mean, first off, we're fully open to ideas, suggestions, how we can improve. I think we haven't got all the answers. So, you know, colleagues globally can help us with that, you know, evidence of what works in a given context, what works against different sort of, how do we be culturally sensitive around parts of the offer that we're providing. In terms of engagement, I think sessions like this really, really help in terms of, you know, getting our message out there, and then others can kind of take that away and go, did you think about X, Y, and Z? And I think during the course of the pandemic, when we've been much more open in terms of the forums that we've created. So, for example, you know, kind of Professor Neil Greenberg's helped us in terms of, you know, well, here's the things to do to kind of help around recovery. much broader groups around sort of faith, spirituality, you know, but let's keep expanding, let's keep talking to see what works in a given context. I'm more than happy to provide my details and the details of the team that people can engage with directly. We always take the time out to talk to people, be that through a technological solution that seems to have worked in a given environment. The things that I'm really interested in, and they're probably applicable to colleagues on this call as well, is keeping it simple. What are the simple things that we can do, and the simple things that we can replicate, but that they also work? So Dr. Paul Litchfield, who kind of chairs the What Works Centre for Wellbeing, I mean, that's his mantra, you know, across organisations that are large, where time is a precious commodity, where health and wellbeing is one of several competing things on, you know, kind of on your agenda during the day. What is it that we can do that's simple? And I really like, you know, kind of Sarah's techniques around, you know, kind of how can you monitor and just check, but, you know, by quick bursts of activity, how can we replicate that? Now we're trying down that health and wellbeing conversations route. Anyone can have a conversation. You know, it's really quick. It's really easy to get into the fabric of organisations. But I'd be really interested to see if there are any other international examples where a similar approach has worked. What have the benefits been? What have the pitfalls been? And again, I'm sorry, I'll bang on about this, but it's about, you know, how do we retain that momentum? How do we keep this going? And that health and wellbeing isn't seen as something that was just there and prioritised during a crisis, but it's something that we cherish going ahead. So the door is open, I think, is my message.
Thank you, Steve. I wonder about things that are not simple. So it's probably not simple for an NHS trust to have an ongoing global partnership with an organisation in a low middle income country. But the evidence is fairly overwhelming about the health and wellbeing benefits of those for all the health professionals engaged in them. Where do we stand on things that are quite complicated rather than those simple interventions?
But for me, I think there's an awful lot of investment that takes place globally in terms of, you know, what interventions work. Whereas, you know, kind of if we're able to say, okay, we can gain a consensus that these types of things will work, you can then start to delayer some of those complexities, would be my initial reaction to that. That you can kind of say, the evidence is indicating, you know, much as Sarah has shared with us, you know, that if you do this type of intervention, this is likely to be the outcome that you will achieve. And I think that can only help, as opposed to seeing lots of colleagues kind of both nationally and kind of internationally trying to solve the same problem. Whereas we could probably gain a consensus that, well, actually, clearly there'll be kind of cultural differences that we'd need to factor in. But broadly speaking, if you kind of back these kind of interventions, that gives you the best chance of creating a sustainable health and wellbeing culture, would be my sense. Sarah, I don't know what your views are. Both Sarahs, which is easy.
I just want to add in, I think it's so important to learn from our colleagues in LMICs. One of my biggest learnings from working in Zambia was actually a lot of the problems are the same. It's just different extremes. And when we're discussing about how to address the user needs of different groups of staff and thinking about diaspora staff as well, actually, that's where lessons learned from LMICs can be very important as well. And like Steve says, this is a global pandemic, but this is also a global issue, which needs to be, you know, which has been highlighted through the pandemic, but actually is relevant to all healthcare systems. And so it makes sense to be working as a group, a collective, and sharing that learning, which is why it's fantastic to have having this as one of its primary agendas, and also having us talk here today and being open and discussing it. So I think this is a really positive move forward.
Thank you. I'm just noticing that Dorcas has said that the Zimbabwean Friendship Bench project model and how it might be useful to the NHS. Don't know if, Dorcas, you want to turn your sound on and tell us a little bit more about that. Yes, no? Maybe not. She don't know.
I've made a note. so I can look
You
that
can
up.
look it up. Okay, I'm sure you could connect with Dorcas at another time anyway. Yeah, so I'm just going to do a bit of a roundup now, I think, unless anybody has any more questions. Oh, Dorcas doesn't know how to turn her sound on. Oh, sorry. I can only see the sort of speaker thing, so I'm actually not. I don't know if you can. Is the answer to that? But if you can speak to Steve afterwards, that would be great. Oh, I can invite you to the stage. Oh, you've been invited to the stage. I think we can hear you now, Dorcas. Oh, she's left the stage. Okay.
Can you hear me?
Yes, we can.
I'm so sorry. We'll get there one day. Thank
Oh,
you.
wonderful. Welcome.
Thank you for this brilliant conversation, which sits very close to my heart. I'm an NHS nurse, A&E nurse from Zimbabwe, and these subjects are very close to me. Not least because I'm seeing more of my colleagues in A&E coming in with anxiety and depression and overdoses, and that's terribly distressing. The Zimbabwean friendship-based model, which I've worked on, has been really successful in addressing anxiety and depression using very culturally accepted methods and models. So it was very much sitting on an HIV program in Zimbabwe with high prevalence of social needs. And what we needed to do in Zimbabwe was make mental health palatable and accessible. So we didn't call depression, we called it kufungisisa. We didn't call anxiety, we called everything problems, because problems are universal. And from that, Chibanda and team developed a problem-solving tool, simply addressing problems. What are your problems? Mother-in-law, finances, housing, marriage, loss of land, etc. And what he did was employ community healthcare workers, average age 55 years old, some poor literacy levels, and train them to administer this tool. And what we've seen is a very successful model that is community-based, culturally acceptable, and rolled out right across the world. I've certainly used it in my population here in London on a project where I was working with young people involved in gangs, many of whom are from minority backgrounds. So I think there are transferable skills here in reversing the pathways of learning. There's evidence here that we can take something from low-income countries, bring it to high-income countries. And my question, I think, to Sarah Al-Shaker was, what can we do for our BAME staff? And I'm certainly a BAME staff who's vulnerable in the NHS. I think these are some of the models that we can begin to look at and see whether there are transferable skills here. But thank you for your discussion. I really enjoyed this one. Thank you.
Thank you, Dorcas. Don't know, Sarah, if you want to quickly come back on that. We've got about another minute.
Not particularly, just really helpful insights, and absolutely agree with everything you say. Like I said, at the moment, we're kind of focusing more on the kind of data. What I'm passionate about is the data collection and that longitudinal, but I think exactly what you've said is those kind of interventions. If we're collecting that data, we can see what kind of impact it makes. And it's about being sensible about the use, considering the user need, and if we think it's going to be appropriate, and making sure that it works. But it sounds like you've done some fantastic work within your department.
Yeah, and I think one of the major learning points from health partnerships is community engagement and ground up community-led intervention, which we're only really just beginning and cottoning onto in the UK context, whereas it's got a very good established and beneficial history in many other countries. I think that's sort of how we use the assets within our community and create community interventions that are acceptable and feasible within a community is something that I certainly learn from every time I speak to our colleagues in other countries. I think we're at the end of our time. This conversation will carry on because Tess is really driving the agenda here on staff wellbeing and the benefits of international volunteering. I'd like to thank our three speakers for their brilliant contributions. very different experiences and work that they're doing, but such an overlap. And I'd like to very much thank THET for driving this agenda forward and for inviting us all here today. Enjoy the rest of your conference.
Thank you. Bye.